I'm not sure, is this the right? Oh, good. I'm not used to this type of setup. I apologize. So I'm Dorothea Frederick. I know that the program says Thomas Jefferson University, which is where I teach undergrad nursing students about neuro, and I do the Kaplan program, and I do health assessment. So this presentation that I'm going to do for you is my capstone project. I just graduated from University of Massachusetts in a dual degree, so I am now actually Doctor of Nursing Practice and Family Nurse Practitioner certified. So we could take the candidate off. It was a long 3 years. Looking back, it was a long 3 years, but going through it, it was a long 3 years. Okay, so now how do I get it to go to the next slide? Use this one. All right, so how did I get to my topic? So when I started this program, I envisioned working as a nurse practitioner student in a doctor's office, and my focus was really wanting to look at metabolic syndrome and doing teaching and measuring outcomes. Working here in the Philadelphia area, we don't have a lot of primary practices that are nurse practitioner friendly, I'm sorry to say. So that being said, that kind of evolved into my clinicals were spent in a home visit practice and then at a CVS Minute Clinic, all of which I loved. So as I was talking to my first preceptor about, my interest in my capstone project, she was telling me about a patient that we were going to go see that day in her home visit practice. And this family had had a caregiver who was their son, and she had seen him, and this was close to a year ago now, but she had seen him, he had been home for the visit, told her everything was going great, talked to her, no problems, and over the weekend he committed suicide. And she came to find that he had told a lot of people that he just couldn't do it anymore, he was at the end of his rope, had never really said anything to her at all. And a lot of you have touched on caregivers with COPD, with the Caregiver app, with end-of-life care. So the more I looked into it in my literature search, the more I got interested in it. So, and then with what brings me here today is a lot of you who are faculty, I don't know if you have the 3 Ps, the poster, the podium, and publication. So my poster was up at UMass. You guys are my first podium audience, so thank you for bearing with me. And hopefully this is under revision in the Journal of Patient Care. So hopefully I will have accomplished my 3P goals for my other job. The literature review revealed that caregiver interventions that improve outcomes for both the patients and the caregivers are in a variety of forms. They're universal, community-based, to very illness-specific and individualized. So they show that caregiver care can be improved when you offer innovations that include self-management, decision support, and the redesign of your delivery of care. So I listed a couple of the statistics that I found for you here. And with the projected rapid growth of older adults, they find that informal caregiving is going to become even more critical in the near future. I did it again. Batteries? Okay. So here I have the definition from the literature of an informal caregiver. So the problem that I discovered was that when you're going to do home visits as a nurse practitioner, you really focus on the person you're taking care of course, which is because that's what your job is. So while that patient receives a really thorough physical and mental health assessment, the caregiver is not your focus of attention. So what I wanted to do was have a simple survey that I could give to the caregiver who was there that could identify their caregiver burden early before they develop physical and or mental health problems, which then would impact both the patient and the caregiver. Aha. So the theoretical framework for my project was stress process theory, and it's described for you here on this slide by Perlin. And the common sources of stress that were associated with caregiving included changes in role function, the additional financial responsibilities, assisting with activities of daily living, dealing with behavioral problems of the care recipients. So caregiving itself, right, creates this context in which caregivers can experience stress and burden. And as we know that people deal with things in different ways, so their methods of coping vary. So the outcomes that you find when you look at caregiver burden are dependent on a lot of factors, and some of the ones I identified in the literature were the available resources, caregiver characteristics, and how that person actually perceived caregiving as a burden. So out of my literature review, I identified 105 scales that were available to measure caregiver burden. So this one that you see up here, the Zarat Burden Interview Survey, was the one that was identified as easy to use, extensively studied, and the shortened version, the ZBI-12, had the best discriminative ability and the highest validity of all the measurement tools. So I wrote and got permission to use this as my survey tool when I went out to see my patients. So then the next thing I did was, using information from my literature review, I matched the analysis of that ZBI-12 tool with the 3 levels of intervention that are comparable to the common typology that you find in public health: primary, secondary, and tertiary prevention. So that's kind of what you see, those 3 levels there. And then based on the score that I would get from that ZBI scale, I would put it into this analysis group, and then I identified a plan of action, which is up here for you. And I don't think that my slide's uploaded, so if you're interested, I do have the plan of action for you as a handout. And then I also identified resources. I apologize, it's very hard to read. But again, I do have them as handouts if anybody is interested in those. So these are my tools that I set out with. I had my survey, I had my plan of action, and then I had the resources that I could provide to the caregivers based on their ZBI score. So my project took place in a home visit practice. There was one physician who would see the patient initially, and then there were nurse practitioners who would go out. And normally we saw patients about every 6 weeks. And my capstone project, the implementation of it, we had 3 months out of those 3 years to actually do the implementation. So I had 3 months to see patients. So this home visit practice is in southern New Jersey. They try to reach senior citizens and homebound patients to provide high quality medical care, keeping them out of the ER, keeping them out of the hospital. So my target audience were primary caregivers of adults over 18 years of age of homebound patients. So as you can see, I didn't go out every day because of course I have my full-time teaching load at Jefferson. So usually we went out 1 or 2 days a week to see patients. So altogether we saw 51 patients. So out of those 51 patients, I obtained 9 surveys. So as you can see, I list my reasons here, and I'll go into that more when I give you my results. So 51 patients, 9 surveys. So I was not entirely pleased with that result, but it is what it is, right? So here are my scores. So you can see here that all my scores, if you think back to my analyses, were all on the low end. Nobody even ranked in the middle of the analysis except for one caregiver, and she had taken care of both her mother and her mother and her husband. She had lost her husband that summer to cancer, was still taking care of her mom, but she was in a support group. She had a family member move in with her. She was getting help. So all of my resources she already had. So she kind of fell out of my intervention also. Okay, so what did I find? Well, the literature search revealed the fact that folks are living longer and informal caregiving is going to become ever more critical, as I revealed. The number of unpaid hours of caregiving provided weekly in the United States is about $1.2 billion, and that's according to Shaw from 2015. Shaw also found that the proportion of caregiving that's provided to people 80 years and older by people of the same age is about 20%. The number of daily hours of caregiving that these elderly people receive is about 1.5 hours. So, during the course of my project, I saw two married couples. Both of them were patients, so one took care of the other. Neither one, so you can imagine, since both of them were patients, neither were in exceptionally good health. One husband who had Parkinson's disease took care of his wife who had Alzheimer's disease, and he fell almost every day. They didn't have any children, so they did have someone who came into the home, but she was just there to help with bathing of the wife. 16 patients, if you remember from that chart, had no caregiver. So one woman who was in a wheelchair would come to the door, scoot herself up to the door. She would be incontinent. She would have somebody who came in, showered her. But for the most part, she was alone until somebody then came back to put her to bed. Her family lived in another state. According to Fitzgerald Health Education Associates, nurse practitioners encounter caregivers every day in practice. So what we have found through the literature is that this gives us an opportunity to practice preventive care. What do caregivers need to take care of themselves? If you can identify these caregivers and the challenges that they're facing, you can provide some support and services, hopefully impacting the negative aspects, keeping them on the positive side. So it involves informed decision-making, creative problem-solving, and strategies to negotiate agreements, because whatever you tell people, right, you have to get their buy-in or it's not going to work. So Sundar 2014, one of my sources, noted that caregiving is very individualized, the meaning that the caregiver gives to these events. Do they see it as a perceived threat? Do they see it as a disruption in their life? That's what's going to impact how they feel about caregiving. So I found that for many of the married couples that I saw, although it displaced the roles they were accustomed to, and it reshaped their life course, it didn't really affect them. It didn't have a negative effect on their well-being. For some grown children who worked full-time, and in Hensel, who worked with Perlin on stress process, said that it's called the unexpected career, thank you, which some people cope with well and some people don't cope with well. So my results were very unexpected. My intention was to survey somebody at every single home, and that just didn't happen. I also hoped to remeasure after I implemented, which also didn't happen. What I did note was that caregivers who rushed home from work because they knew you were going to be there at 1 p.m., so they rushed in the door, they were there for your assessment of their patient, and then they rushed back out. They had no time for my survey. They didn't want to talk about how they were feeling. I think that those, just in my personal opinion, were probably the ones who would have rated really high on that stress scale. Unfortunately, I didn't get results from them. So a big barrier to implementation was that I did not reach these people who came home specifically for the visits or were in a hurry to leave. The other barrier was that some people had no caregiver in the home, and their caregivers lived out of state. So the caregivers who were home all day taking care of their loved one, they were like 0 to 5. They had no stress because that was, their life. They didn't have anything else going on. And I think it's really interesting. I have to talk really fast because I have my warning here. The long-distance caregivers, it would be really interesting to reach them because that if you read it in Family Caregiver Alliance literature, that's like a really big segment of our population. So my results did correspond with the literature in that burdened caregivers are completely focused on the patients and they don't want to spend time completing your questionnaire. I did find, though, that when I wrote up my findings for University of Massachusetts, is that I had focused on the negative aspects of caregiving. And when you talk to caregivers or you looked at some of my surveys with the write-in, a lot of people have positive aspects. Some included strengthening the relationship between the caregiver and care recipient, a feeling of giving back to parents, personal fulfillment because you learn new skills in taking care of patients' ADLs, and a desire to prevent negative outcomes. So my follow-up was that what we need to do is maybe alter that ZBI-12, which really focuses on negative aspects, and let's add something positive. Like, tell me what do you feel that is positive about what you found taking care of this person, and then the other thing is how can we interview these other folks who we can't reach, who are out of state, who aren't home, who don't want to take the time. Maybe getting IRB and then sending out surveys, doing SurveyMonkey. So there were a lot of ways that this could be moved into another translation project, reaching that other population. The other thing that I thought that I wrote up was also maybe just doing that quick 2-question depression scale might even be just quicker because I could just ask you that. So there were a lot of different things. So basically my conclusion is that if we could reach those really high burdened caregivers and implement the interventions that I have on my sheet that you're welcome to look at, we are in that position as nurse practitioners, especially those who do home care, to reach this patient population and help out with caregiver burden. Does anybody have any questions?